my first ICU patient cry because no one believed she was in pain. She kept pressing the call bell, and the nurses kept telling her, "You got payments 30 minutes ago. You were fine." She wasn't fine. Her vitals were elevated. She was sweating and she was terrified. But here's the thing, she was paralyzed on medication. She shouldn't even be able to move, right? Because she's paralyzed. So why did everyone dismiss her? Because pain management in ICU is broken, and most nursing students don't even realize it, and that's exactly why I'm making this video today. In the next 45 minutes, I'm gonna teach you which I knew sooner before my first clinical rotation, before my first clinical ICU rotation. Because when you understand pain and sedation, you don't just learn nursing, you become the nurse that saves life, that saves patients from suffering. Are you ready? Then let's go. Now, real talk. Your ICU patients, they're suffering silently. You might not even know why. You don't even know what it is, but here's why. Problem one, they can't tell you they're on ventilators, they're sedated, they're paralyzed, their body is locked down, but their brain might be screaming. Problem two, you were taught the wrong thing. In nursing school, we learn vital signs tell you pain. Well, in a medical surgical floor, yes, that's correct. But it's wrong. A sedated patient can have normal vitals and still be in agony. Problem three, hospitals are understaffed. Overtired nurses, missed pain assessments. I'm not blaming the nurses because I'm telling you this so you don't become burnt out making this mistake. Now, the result is that the patient is suffering, and when they're suffering, they have slower recovery, which leads to the potential delirium, PTSD from ICU stay. Now, there's one thing that would change your entire nursing career, and I need you to write this down. Oh, at least have it somewhere in the back of your mind. Pain is whatever the patient says it is, whenever they says it. It's not what your vital sign says. You're not monitoring the monitors, you're monitoring the patient, not what you think. Okay, yeah, you go into the patient tells you that 10 out of 10. Oh, but you're sitting down comfortably sipping tea, and you ask them their pain, they tell you 10 out of 10, you're like, oh no, it can't be 10 out of 10. It's 5 out of 10. No, it is what they say it is, even though it looks like that. The patient could be in chronic pain, and they're telling you the 10 out of 10. They might not look agitated, they might not have facial grimacing. It is what they say. So when a patient tell you they're in pain, it isn't for you to decide if they're telling the truth. Your job is to treat it. This one rule will make you a different nurse, a nurse patient trust, a nurse doctor's respect, a nurse who doesn't burn out because you know you did everything you possibly could and you did it right. Let's keep going. So, the pain basic. Let's break down pain. There are two things you need to understand. Number one, analgesia, which is the medication that blocks pain signals. Think of it like putting a volume limit on the pain messages to your brain. Number two, sedation. This is a medication that could keep you calm and sleepy. But here's the trick, sedation meds, neuromuscular meds, paralytics meds, they do not fix pain. They only make the patient calm and sleepy. They do not fix pain. This is where most nurses mess up. They sedate the patient thinking, oh, they are asleep now. Now they don't hurt anymore. Wrong. They are asleep, but they're still hurting. So imagine if you have a broken leg, okay, or a broken wrist, and I give you sleeping pill. You fall asleep, but your wrist still hurts. You can, but you as a patient can't tell me because you're unconscious. You can't complain of pain. You're unconscious due to the medication. Isn't that scary? Isn't that terrifying? Okay. Well, so yes, the rule. Pain patients, it's pain meds plus sedative. Anxious patients, you give sedative only because they're anxious, they're not in pain. And then a paralyzed patient, to those intubated patients, you give payment, you give sedative, and you're constantly monitoring the patient, not the monitor. Of course, you should look at the monitor, you get what I mean, but look at the patient to make sure the patient matches the monitor. Okay? Okay, so now, why is pain hard to assess? Let me show you why pain assessment in ICU is basically like being a detective. Your patient cannot tell you they're on because why? They're on a ventilator, breathing tube, no talking. Well, not all patients, but if you have this patient, that's what you likely see in ICU. They're sedated, unconscious, can't speak. They're paralyzed, can't move, can't point or gesture. They confuse, brain fog. They can't explain what is going on with them. So what do you have? You have their body. Now, you have to watch for facial tension, eyebrows pulled together, sweating, diuresis. That's a very good one. Look at their forehead, look at their armpits. Normally the ICU is always cool, so if they're sweating, something should be thinking ding 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 in your brain. um Pupil dilation, they have the pupil, I've forgotten the name, but they have that pupil thing, pupillator, something like that. Or you could just use a flashlight if their eyes is really wide. Okay, ding 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 ding. Muscle rigidity, their body is all stiff. Restlessness, they're tossing, they're agitated, even with sedative. Your RAS score is like something crazy. So see, when your face is this is pain face. When your face is calm, this is comfortable face. But here's the problem. You might be busy because you're always busy with your patient. You have two patients and you have one that might be in a serious situation than the other. You might not look close enough. You might assume, oh, they're just sleepy when they're actually suffering. This is where you come in. You have to be the advocate. You have to look closer. You have to ask yourself, is this patient truly comfortable or am I missing something? Because some of your patients will be trapped inside paralyzed body, completely aware but unable to move, unable to cry out. And if if you don't catch it, nobody does because you are the eyes and ears and everything. As a nurse, you're everything. So please, please, please catch it. Okay. So how do you actually assess pain? There are tools. For patients who can talk, super simple. Ask on a scale. Okay, Mr. Smith, on a scale of 0 to 10, where are you? 0 being no pain and 10 being the worst pain imaginable. That's it. Now, For patients who can talk, we have the non-verbal ones. You use a skill. Depending on the hospital facility you work at, but the most common ones are the BPS, and this is for ICU. That's the behavioral pain skill. The CPOT, the critical care pain observation tool. Both measure your facial expression, your body movement, and how much they're fighting the ventilator. Now, sorry. Yeah, is the clinical peer nurse's love. If a patient is on sedative and they're restless, eyes twitching, breathing faster than ventilator setting, sweating, they're in pain. They are not anxious, they're in pain. They're restless, eyes twitching, sweating, they are in pain, not anxious, pain. So, because anxiety and pain tend to somehow look the same on the surface, but with pain, you're giving with pain you giving more sedative does not help. You need to give pain medication. If it's breakthrough pain medication like morphine, or you need to give pain medication. This is why you must always assess after you finish giving them the meds, reassess within 1 hour and document. You ask the doctor, is this patient on pain meds? Because the assessment suggests pain, not anxiety. And if the patient is on Tylenol, well, question that. Ask your doctor, can they have a big payment? Normally, there's always the order for it, but if not, if because it's not there, ask for it. Boom, you just prevented your patient from suffering. Okay, I'm about to say something that would upset a lot of people, but it's true, and you need to hear it. Not all, but some nurses are under treating pain in the ICU. Not because they're bad, but because they're scared. Let me explain further. Here's why fear. One of the fear nurses have on patients with medication in ICU is patient might get agitated. Listen, a post-op patient on fentanyl for 3 days, they're not becoming an addict. Pain medication for pain is not addiction. This is a med that is hurting our patients. Number two, patient is drug seeking. Okay. Uh, how can you tell the difference between real pain and drug seeking? It's not. It's. There's not like a scale where you can scale, or there's not like a objective thing you could use to tell the difference between a patient stating they're in real pain or a patient that is drug seeking. You can't. So here's what you do. You treat it like pain because if you guess wrong and it is real pain, you just hurt someone. And if you guess wrong and it's not real pain, the worst that can happen is you give someone pain meds they didn't need. Which wrong answer is worst? The one where you're hurting the patient. The number three fear is that I'm not sure if I should give more. Then call the doctor. That's what we should do. Advocate, say, Mr. John, Mr. Smith, Mrs. Johnson is still showing pain behaviors with our current dose. Can we increase? If the doctor say no and you still see pain, document. Document on your end. I let the doctor know patient is showing some. This is what the patient is saying, and I told doctor, no, escalate the situation. They're not being difficult, they're just trying to be ethical. But you need there are patients right now in the ICUs who are suffering because the nurses were too scared to speak up. I'm not gonna let that be you. You're going to be different. You're going to believe your patient and you're going to advocate for them and you're going to change the system one patient at a time because patient advocacy matters. Now, the dangerous situation. Let me tell you about Mr. Chen. Okay, he came to the ICU post-op from emergency surgery. He had a breathing tube. He was on sedative. The thing gave him paralytics to keep him still. Paralytics means his muscles are locked down. He can't move. He can cry out. Paralytics are also the same thing as sedative. And remember what I said. You have to give pain meds with sedative. But here's the thing. Nobody told him. Paralytics don't put you to sleep. They just freeze your body. So Mr. Chen was awake. He could hear everything. He could feel everything, but he couldn't move. He couldn't communicate that to someone. He couldn't tell anyone. Then the nurse came, noticed his pupils were dilated, and he was sweating through his clothes. But when they looked at the monitor, the vital signs looked normal. So they said, well, his vitals is really normal. It's very perfect. Well, it's fine. The meds are working. He was not fine. He was in agony, trapped inside his own body. I don't know if you've watched that Netflix film. I've forgotten the name of the film, but someone was chasing her, and then they gave her that meds. She could not move, she could not do anything, but she was stuck inside. She could not protect herself from this man trying to hurt her. That's the feeling, helpless, agony. 24 hours later, when the paralytics wore off, Mr. Chen had a complete mental breakdown, flashbacks, nightmares, and we therefore went on to give it the name ICU acquired PTSD. Could this have been prevented? Yes, if someone had recognized the pain signs, given adequate pain medication before paralysis, continued pain medication throughout. The nurse wasn't a bad nurse. They just didn't know better. But now, because you're watching this, you're going to know better. The question is, how would you apply this knowledge? What would you do with this knowledge? Hmm? Okay, let's talk about the actual medications you will see. Opioids, they're heavyweight. Fentanyl is the fastest short acting. Patient gets pain relief in minutes. It wears off quickly, 2 to 4 hours. Uh, you use this for acute pain or when they need to adjust fast. Now, morphine, slow onset, longer lasting. Remember, fentanyl is fastest short acting. Patient gets pain relief in minutes, but it wears off quickly. It's fast acting, it's short. It's fast and then it's also short acting. You use this for acute pain or when you need to you need to stabilize them. And then morphine is more like a breakthrough pain med. It's slow onset, longer lasting, takes 15 to 30 minutes to kick in, lasts 4 to 6 hours. You use this for steady ongoing pain. And then hydromorphine, you might know this as dilaudid. In between is the in between. It acts fastish, but it's medium duration and it's flexible for different situations. Now, critical knowledge. All opioids side effect is respiratory depression. What does respiratory depression mean? You ask. Okay, it slows your breathing. Well, normal breathing is 12 to 20. A patient on opioids, if they are 8, they are in respiratory depression. They are slow breathing, so you have to monitor. But the fix is not to stop giving pain meds. The fix is to give the right dose and monitor vitals. And because they're in ICU, they're probably on vasopressors. You up the vasopressors and and leave the pain meds the way it is. You walk around, you titrate your drips. Okay, so if the patient breathing is slow because of the pain medication, your thought process should go this way. Is the pain controlled? Yes. Good. Monitor close. Is the pain controlled from the symptoms, from everything you're saying? No. Increase those. Monitor close. You never want to. Well, there's certain situation where it goes for you to hold the meds, but in this situation, never think they're breathing slow, so I won't give pain meds. I would hold it. Think, oh, I will need to titrate appropriately while watching the breathing. Okay, maybe the patient baseline of respiratory rate was, let's say, okay, 16, and you notice, okay, they're going 14. Okay, they're still within the limit. You're going 12. What is the trend? Is the pain meds working? And now they are also sedative, propolar, pro, no propolar, propofol, midazolam, dexmedetomidine. It's a mouthful. A reminder: these make you calm, not pain-free. These are sedative. If a patient is anxious and in pain, they need opioid or pain meds, and they also need sedative. I think in ICU we're moving away from opioid type of payments. We're shifting towards tramadol, which is non-opioid payments. So that's something interesting. Don't ever sedate someone's pain away. It doesn't work. It makes them calm and sleepy, but it doesn't fix the pain. Now, you're going to be in certain ethical dilemma, ethical situations you face, and I'm going to go through them. All right, let's talk about situations that you face and that would test your ethics as a nurse or a nursing student. Number one, the addiction history patient. Okay, so patient says, I know I have a history of addiction, but my pain is real. Please don't judge me. What do you think? Do you believe them? Because you checked and they know that we all know that they have addiction, history of addiction. Do you believe them? Yes, the answer is yes. Remember, pain is subjective. So you believe your patient if they tell you they're in pain because yes, they're in pain. You can't say if they're lying or not. If they're in pain, yes, they're in pain. Pain is subjective. Addiction is separate. Treat the pain, monitor closely, use non-opioid options to but treat it. If you punish someone for having addiction history, that's your implicit bias coming out. You just made them suffer. That's not nothing. That's cruelty. Okay, number two, another scenario is the difficult patients. Some patients request payments every few hours. They know the meds. They're those type of patient that say, "Oh, can I have Dilaudid 5 milligram? Can I have my Dilaudid 5 milligram now?" They seem to know too much about the medications, the pain meds. They give you different types. Is this a fraud seeking or legitimate pain? What do you think? Tell me. Just think for a moment. What do you think? Here's the thing. You can't tell. So default to treating the pain. If it turns out they don't need it, fine. But if you guess wrong and it is real pain, you hurt someone. What is the ethical choice? Scenario three, the provider would increase the med. Patient is clearly in pain. You ask for a dose increase. Provider says no. Let's see if they'll adjust. I don't think they're doing this anymore, but it's just something to note of. So what do? You advocate for your patient, especially if your patient is post op. Okay, let's use an example. Let's say your patient is post op vaginal erectostomy. You say, oh, this Miss Smith is still reporting 8 out of 10 pain with current dosing. Yes, you gave them morphine 30 minutes ago. Vitals are elevated, patient is restless. I'm concerned. Is the meds effectively working? Is the medication adequate? Can we discuss alternative? And if provider still says no, you document and you escalate. You document on your end. You document the reason and you escalate. Call the charge nurse, contact patient advocacy, make some noise. But before you do that, always follow the chain of command in your facility, in your hospital. Your license depends on you being the patient's voice. Scenario four would be the elderly stroke patients. Oh, I don't believe in medication. I can't handle this pain. Oh, but then they're telling you they're handling the pain, but they're like this. They're like, they're like stiffing up. They're like grimacing. If you like try to touch them, they're like moving away. This is how you respond. I respect that, and I also want to make sure your body has the resources to heal. Untreated pain slows your healing. It messes up your sleep and it stresses your heart. Let's try a lower dose and see how you feel. You're in control. You're in charge. Negotiate, educate, respect your patient anatomy, and treat appropriately. These are real situations, and how you handle them defines you as a nurse. So, You know what I'm saying? Okay. So, practical tips for your shifts. Okay, you're starting your ICU shift. Here is what you actually do. Tip one, pre-medicate. So let's say patient just had um huge surgery, and it's not the one that you used the laparostomy, the one they had to actually cut them open. And okay, do you want to do dressing change? You want to reposition them? You want to you the PT, that's physical therapy, wants to get them to go for a walk or to do some exercise. You have to do suctioning. Please give pain meds 15 to 30 minutes before you start. Don't surprise them with pain. No, please don't do that. Your number two tip is you want to assess frequently, not just when they complain. Every 1 to 2 hours, look at their face, check for sweating, ask if they're comfortable. Build this assessment into your routine. Every time you give pain meds, you want to ask them if the pain was effective, how the pain. Always ask every time you're doing your vitals, every time you're going to check your patient, always ask about their pain. Remember, pain is a fifth vital sign. Look at their face, check for sweat, and ask, are they comfortable? Okay. Number three, tip number three, you want to think multi. Okay, so you give your patient opioid, and in the next 2 hours, and you know that okay, this should take them to 4 to 6 hours before their next pain med. They're asking for pain. Well, you can really give them the pain meds. Do they have another pain meds like Tylenol or something, ibuprofen that you can give? Yes, if give. No, well, what can we do? Non-pharmacological therapy. Depends on the type of pain. We could give ice pack. We could put music. We could put music, heat therapy. Basically, it means you give pain meds. You give like the opioid morphine. You give ibuprofen or Tylenol, and then your non-therapy pharmacological therapy. It's music, heat, ice, and massage. If it is doable. Uh, if you have more tools, you have better pain control with less medication. Number four, document everything. If a patient reports 7 out of 10 pain with facial grimace notice, with like distraction, diaphoretic, and you gave fentanyl 50 mcg IV, reassess 10 minutes, 15 minutes later, and ask the patient how they're doing. Use your hold cards. If they report 4 out of 10 pain, they calm, they drift into sleep. Document so that when someone else is checking, other nurses, what the doctor is checking, pharmacist is checking, they see what is working, they know that it's working. Number five, listening to your patients. When they tell you something hurts or something feels wrong, please listen. You're not the detective trying to catch them in a lie. Don't do that. That is, do these five things or you're already better than most nurses. Now, here is what I need you to take from this video. Pain is subjective. Believe your patients. Two, assess, advocate, treat, repeat. I think I should put that on a t shirt. Assess, advocate, treat, then repeat. Okay? Three, sedation is not pain relief. Use both when needed. Four, you're going to face ethical situation. Choose the patient. You can change the system one patient at a time. If this helped you, please hit the subscribe button. We're doing deep dives into critical care every week. Next week, we'll be talking about something else. I don't know, it's a mystery. Be ready to be amazed and surprised by what I'm talking about. Okay? Drop your questions in the comment section. What pain management situation scared you the most? I will try to read every comment and I might feature your question in the next video. And hey, I know nursing school is I know nursing school is not easy. I don't like to say nursing school is hard because I believe it varies experience to experience, and I don't like to attach it with negativity. So I know nursing school is not easy, but that is it. All amazing things you do is not easy. I know ICU is scary, but you are going to be amazing because you care about getting this right. I would see you next time. Now go study hard and be the nurse your patient deserve. And remember, you got this.